Day to all. In this video, we are going to see about manual removal of placenta. My name is S. Ruth Kizia. I am working as a tutor in Triple M College of Nursing. Objectives at the end of the sessions, the group you'll be able to define manual removal of placenta, explain the aorta compression that is given during manual removal of placenta, and describe this resuscitation during manual removal of placenta, and you'll be able to enlist the drugs which are used before the removal of placenta and demonstrate wearing long gloves. Okay, how to wear the long gloves in order to perform manual removal of placenta, and understand the actual steps involved during manual removal of placenta, identify the drugs used after manual removal of placenta, and appreciate the vital parameters which are required to monitor the woman after manual removal of placenta. So these are the objectives we are going to learn through this video. Introduction. If the placenta is not delivered within half an hour within the birth of the baby, you have to remove the placenta manually. In case of retained placenta and excessive bleeding, you have to act fast. The woman can lose a life-threatening amount of blood in a very short time. So what you have to do is call for help. Try to stop the bleeding and start resuscitation of the mother. Okay, these are the steps you have to keep it in mind when you see a mother with a retained placenta which is not delivered even after half an hour after the birth of the baby and there is excessive bleeding. You'll have to do this, that is call for help. Try to stop the bleeding and start a resuscitation of the mother. So the first resuscitation would be the aorta compression. Start aorta compression if there is uncontrolled bleeding and the mother shows signs of shock with the rapid pulse, cold sweats and low blood pressure. As you see in the picture, the mother will have cold sweats, low blood pressure, and the pulse will be very rapid, that is above 100 beats per minute. You must perform aortic compression in the following manner. Apply the downward pressure with the closed fist just above the umbilicus, slightly to the left. Okay. So as you see in the picture, you will have to do the aorta compression just above the umbilicus and slightly to the left. So that is where the aorta is located. And simultaneously with the other hand, you will have to feel the pulse of the femoral vessels. So as it's shown in the picture, you will have to feel for the pulse in the femoral vessels. If the compression is adequate, the pulse will disappear, and maintain the compression until the placenta is removed and other resuscitation measures is initiated. So as you see in the last picture, when you do the aorta compression, the blood will not pass through the aorta to the common iliac artery, so from which the uterus gets blood supply. So we are doing the aorta compression. So next is the resuscitation. While you maintain this aorta compression, you will have to start the resuscitation of the mother. So you have to make the woman lie down in a flat bed with the head low and the legs should be up. So you should make sure the blood gets to her head and check the woman's breathing and blood pressure and pulse. So in this time we are doing a life-saving emergency procedure. So you will definitely need an assistant. So this assistant will do the IV cannulation. The cannula size should be 16 or 18. So through that cannula you will have to give 3 liters of normal saline or ringer lactate, 1 bag at a time, and you have to apply pressure to the fluid bag, that is IV fluid, so it goes to the mother as fast as possible. So if there is blood transfusion available at your facility, you can take the blood for blood typing and cross matching and send it to the lab. So what are the drugs before removal? You have to make the mother to calm down, because you are doing a lot of procedure for the mother. So the mother will have normally the mother will have this anxiety, so and also the pain. So you have to give some drug for the mother to sedate her. So the drugs given before the manual removal of placenta for pain relief is the diazepam intramuscularly or intravenously in cases of excessive bleeding, and aorta compression you can give 10 mg of diazepam intramuscularly or intravenously for the pain relief. So next is the glove. So unlike the other procedure, the gloves you're wearing now should be till elbow to make sure your hands are not contaminated and you're not infecting the mother, because you will have to insert your insert your hand at least till the wrist. So you will have to wear an elbow gloves. So put on the elbow gloves sterile if available. Otherwise, use a normal sterile glove. Even non-sterile glove could be used if at a severe bleeding, and that is a matter of life and death. So this is gloves wearing is very important while doing the manual removal of placenta. So now we come to the actual procedure. That is, first you have to call for help and do the aorta compression and start the resuscitation. So for resuscitation, we will do this blood pressure and pulse and breathing monitoring, and you have to insert two big IV cannulas, and through that you have to flush IV fluids, that is ringer lactate or normal saline. And if the blood transfusion is available in your facility, you will have to start the blood transfusion. So after resuscitation of the mother, now we come to the actual procedure. That is removal of the placenta. How you have to remove? Ask for the woman's consent. Insert a hand into the vagina and follow the cord into the uterus. See, as it is shown in the picture, you have to trace the placenta by tracking the cord. Okay, so you grab hold of the cord. Okay, follow the cord into the uterus, so you get to the margin of the placenta. So place the other hand of the top of the fundus to support the uterus. Keep the fingers tightly together. So your whichever hand you're putting in, probably the dominant hand, the right hand, your fingers, all the four fingers, the index, middle, the ring finger and the little finger, you have to tightly hold together and move your hand slowly from side to side until the edge of the placenta is located. So as it's shown in the picture, you can see they are sweeping from side to side to locate the margin of the placenta. So once you locate the margin, you can separate the placenta and from the uterine decidua. Next, use the edge of the hand to gently separate the placenta from the uterine wall, as it is shown in the picture. And uterine wall is very fragile. So at this condition, the uterine wall will be very fragile. So you should be careful not to apply any unnecessary force. And proceed slowly all around the placental bed until the placenta is detached from the uterine wall. So it is shown in the picture, the complete hand you are inserting into the uterus. So once complete placenta is detached, so until then you have to proceed very slowly by separating the placenta from the decidua by sweeping your hand from side to side. The same way, same time you will have to apply the aorta compression. Now slowly withdraw the hand while the other hand provides a counter traction in the other direction. So when you withdraw the hand, along with your hand, the placenta will come out if it is separated. Okay, and palpate the uterine cavity as is shown from the first picture. Palpate the uterine cavity, ensure all the placental tissue has been removed. So you will have to palpate all the four sides of the uterus, that is the anterior, posterior and the two lateral sides. You'll have to palpate and make sure that all placental tissue has been removed. In rare instances, a placenta can be invasive, and it is sometimes it may be impossible to remove it completely. That means retained bits of placenta may lie into the uterus attached to it. So sometimes it may be invasive. It goes into the myometrium, so we're not able to detach it properly from the decidua. So there can be a rare instances like this. So that time what you'll have to do, the following bleeding. So that time there will be bleeding. Okay, so that bleeding must be controlled with bimanual compression and aorta compression. So as it is shown in the picture, you can see the bimanual compression and the aorta compression, and you have to do the balloon tamponade and refer the patient. So what is uterine balloon tamponade? So uterine balloon tamponade is unstoppable. So if the bleeding is unstoppable by active management of the third stage of labor, then in order to prevent hysterectomy, you can perform a uterine balloon tamponade. The indications are profuse uterine bleeding, And the prerequisites, so these are the conditions that is required before doing a uterine balloon tamponade. The prerequisites are: you need a skilled health personnel, exclude other causes like there may be a retained products, so other causes should be excluded, access to blood products, and you need at least 2 to 3 pints of blood transfusion unit, and immediate recourse to surgical intervention. So if at all there is a bleeding after doing a uterine balloon tamponade, you have to recourse your action to surgical intervention. So the OT must be ready to perform any surgical intervention. And implemented primary, that is a primary PPH, first line of treatment, is already implemented, and it is not giving any good result. So that time you can go for the uterine balloon tamponade. And adequate monitoring for any signs of deterioration. That is, adequate monitoring means you need a continuous cardiac monitoring. Okay. The tools required are sterile cloth, IV fluids, sterile gloves, sterile condom, IV fluid set, ligature, clamp that is non-traumatic, minimum 25 centimeters, headlight, and two broad specula, that is speculum, vaginal speculum. So how to do it? Stop the bleeding by external compression of the aorta. So only then you will be able to visualize the field. Otherwise, the uterus and the cervix and the vagina will be pulled by blood. Okay, so you have to do external compression of the aorta in order to visualize the cavity. Okay, and keep the fist in position until the condom tamponade insertion has taken place. When mounting the condom, that is attaching the condom to the plastic tubing. When mounting the condom on the plastic tubing, be careful and maintain sterility. So as it is shown in the picture, you will have to attach the condom and the plastic tubing. Okay, so they are ligating with the ligature. Tie the ligature carefully several times around the condom below the knob on the plastic tubing. Next is the procedure. You will have to clean the vulva, insert the lowermost speculum so you can visualize the cervix, insert the second speculum anteriorly and place in a similar position. So while inserting the speculum, you have to make sure that there is no vaginal mucosa is between two specula and should be avoided because it will be very painful. And use long clamp to insert the tubing into the uterus. Okay. So this tubing which is attached with the condom, it should be inserted into the uterine cavity. So for that insertion, you will have to use a long clamp which is at least 25 mm long. And next is be careful not to grasp the condom but rather grasp the tubing. So if you grasp the condom, what happens? There may be some pores, okay, that will lead to leakage, and the ultimate aim of the procedure will be lost. So you will have to grasp only the tubings while inserting the condom into the uterine cavity. Insert until the condom disappears into the uterine cavity. Fill the condom with fluids. So start with 500 ml. It is normal that the condom is leaking a little bit. It doesn't matter. Continue to fill the condom until the bleeding stops. Okay. If 500 ml is not enough, infuse more. Then you can keep the infusion line open to compensate for any loss during leaking. Pack the upper vagina with roller gauze to prevent expulsion of the balloon. So at this time, you have to give oxytocin 20 units in 1 liter of normal saline, or ringer lactate at 60 drops per minute. A single dose of antibiotics is recommended. For example, ampicillin 2 gram IV. Next is the post-procedure care. Once you insert the uterine balloon tamponade and the bleeding is controlled, you will have to monitor the vital signs, uterine fundal height, vaginal bleeding, and you have to monitor the urine output every hour. Condom can be kept inside the uterus for days if transport is needed. Otherwise, after 6 to 4 hours, if there is no active vaginal bleeding, deflate the balloon. If there is no vaginal bleeding after 30 minutes, stop oxytocin. And if the woman starts to bleed when the balloon is deflated, insert a new balloon and recommence the oxytocin infusion. Prepare for surgical interventions when her condition is stable. Remove the urinary catheter once the woman is stable. So while doing a manual removal of placenta, this can be prevent postpartum hemorrhage, and you can save the mother's life, and you can protect a mother from going into a hysterectomy. So remember never to refer a woman with uncontrolled bleeding or retained placenta. So because it is not safe, you must stop the bleeding and remove the placenta wherever you are. So that is the golden standard we have to remember while doing a manual removal of placenta. So I think you have learned something about the manual removal of placenta. So what is uterine balloon tamponade, and what is resuscitation? What you have to do in kind of when you do a resuscitation one by one, and what is aorta compression? Okay, thank you all.